I'm going to talk about focused ultrasound. Something that some of you will know a lot about, and maybe some don't know as much about. So I'll kind of start at the beginning and try to cover what we know today. Just a few disclosures. I used to always say that focused ultrasound didn't have any approvals for the brain, but we're so excited that finally there's an FDA indication to treat patients with essential tremor, and that really just happened 2 or 3 weeks ago. And then I'm appreciative of the support we get for our essential tremor and Parkinson studies, which are relevant here. We do get industry support and some support from our state in Virginia, as well as some private donors and foundations. And then I serve on an advisory board for essential tremor. And just to start off, a few comments. I know this is a John Jane lectureship, and it's so appropriate that it's here because he was such an advocate and enthusiast for learning, and especially in neurosurgery or neurosciences. And I just want to touch on a few of his contributions, even in the field of movement disorder surgery. This is a picture of Dr. Jane with Paul Busey. Paul Busey's credited with really probably the first surgical procedure for tremor. He was very interested in the cortical spinal system or the pyramidal system, and believed that the Betz cells or the pyramidal cells in the precentral gyrus are responsible for involuntary movement disorders. So it's the first surgeries that he performed involved resection of the precentral gyrus, and obviously associated with a lot of morbidity, but that was really started the treatment for tremor and other problems. And Dr. Jane was at University of Chicago with his mentor, Paul Busey. And he worked in he was always an enthusiast for pathology, and when he was a pathology resident, he did some studies on Dr. Busey's patients. This is one that went to autopsy. It was a case series, single case report, where he actually quantified the pyramidal tract and the contributions from the precentral gyrus to the medullary pyramids, and that had implications for movement disorders. And later, he actually performed some cortical spinal tract lesioning procedures. The procedure kind of evolved from the cortex to the subcortical areas like the cerebral peduncle, and Dr. Jane performed some of these early pedunculotomies and even published on that for the treatment of involuntary movement disorders. So he wore so many hats. I think really his favorite hat, though, was as an educator. He was one of the greatest educators, I think, across any field. He really loved students and residents and even colleagues, and he liked learning so much. This is a picture. I was fortunate enough to train with him, as did so many people over 4 decades. He really, I think, could train anyone. And here's Dr. Delishaw a few years prior to me. So he, a lot of people really, I owe a lot to him, and I think it's really appropriate that there's a lectureship here at such a vibrant place that's focused and dedicated towards learning. So I'm going to start off the talk just talking a little bit, just a few comments about where we stand with movement disorder surgery. We've evolved a lot since the early Busey procedures, in the 40s and 50s. There's a few things that are for sure. We definitely have very precise stereotactic devices. There are a lot of frames, different types of frames. There are frameless systems. They're all precise to like a millimeter, and people are trying to talk about sub-millimeter precision. So we have very good devices for delivering things into the brain. We have class 1 evidence that deep brain stimulation is effective for Parkinson's disease. And so there are not a lot of things in medicine that we have class 1 evidence for, but this is definitely one of them. And then we're really able to take advantage of the latest advances with MRI. This is really advancing movement disorder surgery. The ability to visualize the targets that that we treat. Here you can see. Here you can see this is a 1.5 Tesla MRI, and you can see the kind of the signal to noise ratio is not quite as good as a 3 Tesla. Start to see a lot more of the basal ganglion. And here's a 7 Tesla MR. You can see the substantia nigra. The subthalamic nucleus and the globus pallidum. So we're really able to visualize more and more things every day, and that'll just continue, as we proceed, with different types of treatments. We're also getting some advances in the devices or the technologies. This is a multi-directional electrode. So basically, we can steer the therapy to the areas of the brain that we need it, and avoid areas of the brain that we don't want to treat. So this is really going to make the surgery even more forgiving and available to more people. And then there's more and more laboratory evidence that suggests that smart DBS devices will really be the way of the future. This is closed loop stimulation, so that means recording from the brain and delivering the treatment. So this is in laboratory where the stimulation is based on recordings from the motor cortex, and it really in this particular laboratory experiment showed that palatal firing is decreased and oscillatory activity is decreased, and movement for the animals is increased. Several different ways to measure kind of the effects of the stimulation. So I think we're going to see more and more smart devices, I think, that are available and that are safer to implant. So that's kind of where we stand today with movement disorder surgery. It's very exciting. There are more and more people being treated safely and effectively. So I'm going to talk about a different modality of treatment, which is focused ultrasound lesioning, and that's really a step in a different direction from deep brain stimulation. It's really kind of a shift in the concept of treatment, and I think it might be kind of a third era of lesioning. We've been through this concept of lesioning the brain before for movement disorders. It really was the first therapy for movement disorders back in the 40s. Was really when the first stereotactic devices were developed. They actually were developed kind of as a means to avoid a frontal lobotomy. So, instead of disconnecting the whole frontal lobe, you could treat areas deeper in the brain, like in the thalamus, very precisely where all the fibers converge, and do disconnections much more precisely or elegantly than disconnecting the whole lobe of the brain. So that started kind of this concept of stereotactic surgery. And it really became very pertinent in Parkinson's disease. But when levodopa was discovered in 1968, Parkinson's surgery really disappeared. And movement disorder surgery kind of went into a hiatus. Obviously there are side effects from chronic medication use, especially dyskinesia, motor fluctuation. So movement disorder, stereotactic ablations were then revisited with pallidotomy procedures in the 70s and 80s. And so it's kind of like the second era of lesioning. And then deep brain stimulation came along and lesioning went away again. So it's kind of like we're revisiting this concept of lesioning. I wouldn't say that lesioning's been abandoned every time because of lack of efficacy. It's just that there were different treatments that have kind of relegated it to kind of a second line therapy. So the question is, really, can we lesion the brain effectively for patients in this era of DBS treatment? And that's what I'm going to talk about. The ultrasound is not that new. It was really discovered in the 50s. And I just want to say a few comments about kind of the discovery. In the 50s in Lund, Sweden, a cardiologist named Edler borrowed an ultrasonic reflectoscope. This was a device that was made actually by the Firestone Company here in the U.S., and it was used mostly in shipyards and factories to kind of assess the integrity of the materials. So Edler knew about this technology and actually took one of these devices in Sweden and put it on a patient's chest, and he performed the first real echocardiogram where he's able to see valve movement of the heart. And that was back in the 50s. One of the doctors in his hospital was Lars Lexell, who's really kind of the father of gamma knife radiosurgery and a lot of other things in stereotactic surgery. He's really a pioneer in my field. And Lexell learned about what Edler was doing with the heart, and he was very interested in less invasive types of things. And he started to use this device to sonicate or visualize the brain in neonates, with through their fontanelle or through thin skulls. He could actually detect hemorrhages in babies. And he actually was very interested in ultrasound and got several patents over the course of his lifetime. He even tried to modify his Lexell frame and arc to accommodate an ultrasound transducer to do ablations in the brain. But Lexell eventually abandoned using acoustic energy or ultrasound because the problem was you could never really send it through the human skull or the adult skull. It always required a cranial window. So he got much more interested in ionizing radiation and then went on to develop the gamma knife for stereotactic radiosurgery. So about the same time that ultrasound was being developed in the U.S., a group of brothers, Frank and William Fry, were ultrasound physicists. They were studying this in Illinois, and they developed this concept of focusing ultrasound beams for therapeutic effect. And I'm going to show just a video of their first device that they used to focus ultrasound beams. It's basically the first focused ultrasound device. It's a 60-year-old movie, so I just want to take the opportunity to show it to you. I'm not sure if the sound will play, but I think you'll be able to see their device. And then they presented their work in Philadelphia at the AANS a long time ago. And here, I don't think we can hear the sound, but that's all right. Here's an early animal brain, and you can see that they performed a very precise lesion just in the cortex. And they thought it was really a great modality for, here's William Fry and his first ultrasound device, which was really 4 transducers that focused to a single point. And the device weighed about a ton, so it was very large. They used it for experimental neurology, they called it, but they were interested to bring it into human clinical trials. And so that was really kind of the origin of focused ultrasound, was really back in the 40s and 50s in Illinois. They eventually teamed up with a neurosurgeon. This is Russell Myers. Russell Myers was a chairman at Iowa in the 50s, and he's really one of the pioneers of movement disorder surgery, not really stereotactically, but he developed open craniotomy procedures to lesion the basal ganglia. So these were really the first extrapyramidal lesioning procedures, which were different than the ones I talked about from Busey, which were pyramidal lesionings. These were extrapyramidal lesions where there weren't a lot of hemiparesis or paralysis from the procedure, but there was a lot of morbidity, obviously, with open cranial surgery of the basal ganglia. So Myers got very interested in teaming up with the Fry brothers to try to do these lesionings of the basal ganglia in a more minimally invasive fashion. Here's a series of 12 patients, I think, where they treated, and a lot of them had tremor and athetosis and other involuntary movement disorders. But it was never really adopted. It required this large device and cranial openings to basically a craniotomy to send the sound waves into the brain. It's never really adopted for use in neurosurgery. So just a few comments about the physics of ultrasound and what's going on. It's called ultrasound because the acoustic frequencies are at frequencies above the threshold for human hearing. So humans can hear between 20 and 20,000 kilohertz, or frequencies in that range. Anything above 20,000 kilohertz is termed ultrasound. So ultrasound occurs at frequencies above those for human hearing. And ultrasound is basically a pressure wave where a pressure wave will move through tissue, and as it moves through the tissue, it displaces the tissue, and molecules will reverberate. And if you focus them at a single point, that pressure, frictional energy from the pressure wave is hundreds of times stronger than at the single. Than from the single wave. So high intensity focused ultrasound achieves pressures of like 1,000 watts per centimeter squared, and that's enough pressure to ablate tissue. So that's kind of a therapeutic threshold for an ablation. I think another important thing about ultrasound is that not all frequencies move through tissue at the same rate. The higher frequencies don't move through bone very well. So like the types of frequencies that we use for sonography and echocardiography and diagnostic ultrasound don't transmit through the skull. Kind of the mid-range frequencies like 1 megahertz or a little bit less will transmit through bone tissue. So those are the frequencies that we're trying to take advantage of for a brain treatment, a frequency that might travel through human bone. It is important to recognize, though, that most of the ultrasound energy is absorbed by the bone or reflected. So probably about 90% of it doesn't, probably only about 10% of it makes it inside of the brain to a point where it could be focused. So most of it is reflected or absorbed. And so I mentioned that ultrasound really never took off when it was conceived, but in this past decade or so, there have been some real advances in ultrasound technology so that we can now send ultrasound through the skull. And that's why there's so much enthusiasm for focused ultrasound, is because we're taking an energy that's kind of recognized as more benign, even though it's capable of ablating tissue. But we're sending sound waves through the skull and then achieving kind of major clinical effects. So two of the real advances in ultrasound technology were the development of a multi-element phased array transducer. So that's basically a transducer with a device with 1,000 elements in it, 1,000 different elements capable of sending 1,000 ultrasound beams. They're arranged in a hemispherical pattern, kind of like a helmet or a hairdryer, where they can send sound waves that will converge to a single spot. And they're phased array, or they can be phase shifted. So you can you can phase shift them so that they all reflect through the bone and focus at a single point. And then we take advantage of kind of high resolution CT imaging to really make predictions about how the ultrasound wave will reflect through the skull. So I think of it as kind of like a stigmatism for your lens, where the light, people with astigmatism, the light comes into the lens and then it's diffracted. But we really need to focus it. And so we're kind of able to correct the astigmatism so that it all comes into a focus deep inside the brain. So that was the real advance in the past decade or so that's kind of brought this technology back into the clinic. This is really the first closed skull treatment in humans. So it was at the Brigham in 2009 or so, where they really conceived of the idea of ablating brain tumors. These are malignant gliomas, and they took a transducer that really only had 500 elements, and they were able to heat up the tissue but not get enough power to the target to ablate tissue. But it really showed that it was possible to send ultrasound through the human skull in awake people, monitor it with MRI, and actually achieve some heating. So that was a huge advance. There was a kind of an advance or an update in the ultrasound transducer technology, where there were more elements and more power. And then in Zurich, Switzerland, Daniel Gilmanode was able to actually achieve tissue ablation in patients with neuropathic pain problems. And that's really kind of when we got interested in focused ultrasound, because we saw some of these small medial thalamotomies that were really precisely placed by Daniel and Joe Minot to treat pain problems. And obviously you could see, well, that's a pretty incredible event to focus 1,000 ultrasound beams to like a millimeter or two target. So we got interested in focused ultrasound to treat tremor. And it was not really like widely accepted as a great idea. I would say in my field, most people think of brain lesioning with some of these kind of early lesioning procedures. This is Walter Freeman, who pioneered the frontal ice pick frontal lobotomies, and there have been some misadventures in brain lesioning procedures, and it seems okay to lesion the brain for a brain tumor, but not for a functional disorder or kind of like a normal brain that's just afflicted with a psychiatric disease or a movement disorder problem. So lesioning had kind of disappeared in our field and was not really recognized as a great idea when we thought that maybe lesioning someone for tremor would be a good idea. The critics all said, well, this is a permanent ablation, and we have DBS as a really state-of-the-art technology, and you can't do bilateral lesions; they're dangerous. And so that was kind of the early criticisms that we heard, but we really liked the idea of doing this procedure for essential tremor for a few different reasons. One is that essential tremor is a really common problem, and there's a good treatment for it. Deep brain stimulation therapy works great for essential tremor, but the patients don't really embrace it too much. They don't like the idea they perceive it as invasive or too invasive for kind of a benign chronic condition. So it's not really widely accepted in the ET community, but a lot of them are disabled. We really know the target to treat tremor really well, the ventral intermediate nucleus of the thalamus. If you target it accurately, it stops tremors really well. That's been known for decades. And then we like the idea of kind of matching this technology to the problem. The possibility of doing a little bit of a treatment, checking the patient, and do a little bit more treatment, checking them again. We really like the idea that we could follow tremor as a symptom to kind of guide the treatment. So it seemed like a really good match of the technology to the problem. And we designed a pilot study back in 2011 and treated 15 patients. We were able to ablate the ventral intermediate nucleus of the thalamus in all of them. We really carefully characterized this lesioning process to see if it was different than other lesioning processes. This is an MRI study where we showed all of our results for this lesioning process. It really images a lot like an ischemic infarction in that you don't really see a lot of the MR changes in the real hyperacute phase. But the earliest changes you see on diffusion-weighted imaging, like a stroke. And then over the course of a few hours, you start to see it on T1 and T2-weighted sequences. And we saw with susceptibility-weighted imaging, we saw blood products at the target in all the patients, but we never really saw any overt hemorrhages. So we thought that it kind of behaved very much like a small ischemic infarction. We went back to the laboratory, kind of like reverse translational research, and to try to see how it compared to other lesioning procedures. And here's in an animal model, we did focused ultrasound thalamotomies, radiofrequency thalamotomies, and gamma knife thalamotomies, and we compared them, the MR evolution of the lesion and the histology, and we thought that focused ultrasound would be a much sharper lesion, that the ischemic penumbra would be real minimal compared to traditional lesioning procedures. And that wasn't really what we found. What we found was that it was just like thermal lesioning with radiofrequency. It was just performed without a radiofrequency lesioning electrode. So, and then thermal lesioning was much different than radiation lesioning. And we simulated all the dose, the thermal dose and the radiation dose, and kind of try to compare them as best we could. And this kind of demonstrates the theoretical advantages of thermal lesioning over radiation lesioning first of all, the effects really immediate, whereas the effects of radiation lesioning require much more time. They're more latent. And then the drop-off of the dose is much sharper. So in other words, these are radiofrequency and focused ultrasound dose curves, and you can see that the dose drops off in just 2 or 3 millimeters. There's almost no treatment beyond 3 millimeters. Whereas with radiation lesioning, you're still getting like 10% of the dose out to 9 millimeters or so in this animal model. So the gradient for effect is very sharp and very immediate. So there's some theoretical advantages of thermal lesioning over radiation lesioning. But anyway, back to the pilot study. If with the lesions, with ablations in the ventral intermediate nucleus of the thalamus, we were able to stop tremor or to significantly suppress it. And here you can see spiral drawings. These are the patients before. Here you can see the spiral drawing immediately after the treatment. This is the same day. This is 1 month, 3 months, 1 year. This is a really great result where the patient had no tremor. Here's our worst result. We did 15 patients. 2 of them, over the course of 1 year, lost some of their tremor benefit to a little less than 50%. This is kind of like, this is like Swedish lesioning and UVA lesioning. So here's, anyway, here, look, you could see that the patients got, that good therapeutic effect, and then it wore off over the course of a year. So we had 2 patients out of 15 where the effect kind of wore off. And I think what happens is that the lesion heals a little bit too much, and you start to see, some recurrence of the symptoms. So definitely, and one other thing, importantly with any lesioning procedures is safety. No one's going to be interested in lesioning if it's not safe. So we characterized our side effects from the procedure. We saw a lot of paresthesias or sensory effects that are kind of the types of effects you see with a thalamotomy. Most of them tended to go away or be fairly mild. We did see some unsteadiness and ataxia and balance issues, and those didn't happen very much and tended to go away as well. So our side effect profile, I thought, was very minimal, but we did have a little bit of wearing off. So I think that lesioning is kind of a balance of durability versus side effect risk. And I think in our earliest pilot study, we did we kind of focused on safety and low side effect profile. And some of the, one of the issues also, we did quality of life measures and some disability ratings. And really the issue is, we thought the tremor effect was pretty significant, comparable to a DBS, but what about the quality of life issues? Some of the critics would say, what about DBS? You could apply it bilaterally, whereas a thalamotomy procedure just do unilaterally. So we went back to look at bilateral cases versus unilateral cases. These are bilateral DBS cases, and unilateral DBS and unilateral focused ultrasound. And not to say that if we stop the tremor in your dominant hand, that's just as good as a bilateral DBS. We wanted to see how much functional improvement did people get treating the other side. So we thought that definitely if you stop the tremor in someone's dominant hand, they have a lot of functional improvements in day-to-day life. But we wanted to try to get an idea or measure how much benefit do they get if you add the other side or the non-dominant hand. So this was an effort to do that. If you look here, all of the 3 cohorts all had roughly the same amount of hand tremor improvement. This is like 75 to 80% hand tremor improvement. The bilateral DBS patients had a lot more control of their total tremor. So that's like their head and neck tremor, their vocal tremor, their hand tremor, their leg tremor. When you measure all of the tremor, they had much more effect, statistically more effect than unilateral cases. More improvement with axial tremors than the focused ultrasound. But the disability scores and the quality of life scores were kind of similar. So I think that you get a lot of benefit or functional benefit from controlling that dominant hand tremor. But you definitely get more improvement by adding the other side. So that was kind of the take-home message just from that retrospective study. Other groups also replicated our findings. These are hand tremor scores, 79, 80, 73% in Toronto and Korea. So it looked like that it seemed like a feasible type of procedure to at least investigate further. So we designed a randomized controlled trial, kind of a pivotal trial to really test and determine the efficacy for this procedure. It was performed at 8 centers. UVA and Swedish were 2 of the major centers. I think there were some real novel aspects to this trial. First of all, it was randomized so that patients went to the treatment or a control procedure. The control procedure was a sham procedure. And we don't use a lot of sham procedures in clinical trials or in surgery, but this technology is pretty amenable to a sham procedure in that the patient's in the MRI, it's really loud, it seems like there's a lot going on, but you could just set the power of the ultrasound to 0. So it seemed very ideal for a sham procedure. There are a lot of critics that said, well, I don't think you can, the disease might not be a great disease for a sham procedure, but we really wanted to investigate as rigorously as possible because there's definitely a lot of sham effects in Parkinson's disease, and it's not that well known with essential tremor. So anyway, patients were randomized in a 3-to-1 fashion to either sham procedure, where they got a head shave and a frame, went into the MRI and had basically the same procedure, but the ultrasound was turned off, versus the focused ultrasound. They were blinded for 3 months. The raters were blinded. Another novel aspect of the trial was that the ratings were videotaped and mailed away to a group of neurologists not involved in the trial. So these patients weren't rated by me or by neurologists in our center. They were videotape rated by people not involved in the trial, who actually were experts in ET. So I thought it was a very rigorously designed trial. Basically, the eligibility or criteria, the patients had to have ET, essential tremor diagnosis by a movement disorder neurologist. It had to be severe and disabling and refractory to medicine. We had criteria for that. There are a couple other issues. The best candidates for the trial had asymmetrical or unilateral disease. There are issues of an MRI. Some patients with pacemakers aren't candidates. People that are claustrophobic aren't candidates. So that's a little bit of a new issue for us. And then there's the issue of skull characteristics. There are not any other procedures where we really worry much about the patient's skull. Usually in neurosurgery, we can get through any skull. But for this particular procedure, we have to worry about the skull. So we get CT images and try to calculate how acoustically favorable or unfavorable they are for this type of treatment. And not all heads are really, the same. So our outcome measure was really the hand tremor at 3 months, comparing the treatment to the sham group. We did this hand tremor subscore. It's basically a rating scale for essential tremor, but we took 8 of the items for hand tremor and summated them. So it was as many of the hand issues that we could use to rate their hand tremor. And we had some secondary endpoints with quality of life and disability and that type of thing. The conduct of the study, I think, was really good. The cohorts were exactly matched. There were no statistical differences between those that got a sham or those that got the focused ultrasound treatment. We assessed the blinding process, and it seemed like it was pretty rigorous or accurate. Here you can see the number of correct guesses by the patients immediately after the procedure and then at 3 months. Here the assessors could predict or guess the treatment mostly by what they perceived was the effect in 70% of the cases or so. The accountability was really high. Most of the patients made all the treatments. 97% of the study visits at 3 months had been achieved. So I think it was a pretty rigorously conducted study. And this is the main take-home message, is that there wasn't much improvement in the sham cohort, the 20 patients that got a sham procedure. whereas the improvement in the focused ultrasound thalamotomy cohort was statistically different at 3 months, which was the primary endpoint, and then at 12 months, which was the secondary durability endpoint. So we met our primary outcome measure, and then there were disability gains similar to what we saw with pilot studies. So the FDA has kind of spilled the beans on this trial. It just got FDA approved 3 weeks ago, and they released the results. And I think it's, very exciting for people with essential tremor because they now have more options or more choices to choose from for treatments. Now I'm going to shift gears and just say a few things about Parkinson's as well. Parkinson's disease is a more complicated disorder than an essential tremor. There are more symptoms than just tremor. And all of the treatments, or not most, but all of the treatments that we offer people with Parkinson's disease are symptom palliation oriented. So we're treating symptoms. We're not protecting them against progression of the disease, and we're not curing the disease. So those are the real goals for Parkinson's in the future. But for now, the question is, what is a good symptomatic treatment, or the easiest, best symptomatic treatment for a patient? And so, the role for focused ultrasound in Parkinson's disease is totally under investigation. This is a patient with tremor-dominant Parkinson's disease. So there are a lot of different flavors of Parkinson's disease. This is a patient with a very purely tremor-dominant subtype. This purely dominant tremor subtype, as defined by this equation, occurs probably in like 8 or 10% of people with Parkinson's disease. There are others that have akinesia, rigidity, or other types of postural instability, gait disorder types of symptoms. But this really purely dominant tremor subtype is about 10%. So we thought obviously the next step in the investigation of focused ultrasound would go from essential tremor to Parkinson's, and then maybe more complicated Parkinson's problems. So we developed a clinical trial to look at tremor-dominant Parkinson's disease, and we did that with Swedish. And this was a very kind of similarly designed study, although smaller. Patients were randomized to a sham procedure. They were rated by videotapes. The primary outcome measure was at 3 months, but we followed them for 12 months. We added cognitive testing to this, as another measure for safety. So kind of an iterative advance, in the investigation of the technology. This is kind of a diagram of the trial. We've completed the trial, but we're still getting all the results together. 20 patients went to the treatment, 7 went to a sham, and then the primary outcome was this 3-month blinded assessment. And a couple of people fell out of the follow-up. We lost one of the shams to follow-up. 3 of the treatment failures went to DBS. So, we're in the process of assimilating all the data, but I'll present that in just a second. I'll just say a few words, just a comment about sham procedures. The idea of the sham is that we'll control the placebo response, or actually measure the real treatment effect minus the placebo response. And there's some ethical issues of sham surgery. Are you exposing someone to more risk with a sham procedure? Some people think sham procedures are unethical. My opinion is that it's better to really determine the true effect in a small number of people early on than to expose a lot of people to a treatment that might not necessarily be as proven as we think. So anyway, Parkinson's is one of the classic diseases where placebo response has been measured in medication trials and in surgery trials. In the 80s, there were there's a fetal transplant trial where some of the patients received just a burr hole, and they improved their Parkinson scores by 20 to 30%. That's almost as much as you see with DBS from just going through a neurosurgical procedure. So everybody knows that the more intense the treatment, kind of the more intense the placebo response from the body. So, and these are just 2 studies to try to further convince you that there's a physiologic effect from the placebo response. These are patients that are undergoing DBS procedures. They have an electrode in their subthalamic nucleus, and then they were randomized to get a saline injection or a dopamine injection. And the patients that got saline injections had a similar type of response from the neurons in their subthalamic nucleus as those that got the levodopa injection. And similarly, PET studies have been done where patients got a placebo injection and there was an increased release of dopamine in their striatum. So it's definitely there's a physiologic response to placebo, and it's important, I think, for us to distinguish that from a true treatment response, like from focused ultrasound. So we've done sham procedures. These are the results in Parkinson's tremor. You could see that the focused ultrasound cohort had an improvement in that hand tremor score the same score we used in the essential tremor. And also in UPDRS, that's a Parkinson specific rating scale. So they had improvements in the tremor scale and improvements in the Parkinson scale. When you compare them to sham, the sham procedures, you can see there was a little bit of improvement in the sham group on the tremor scale, 16% improvement at 3 months versus 52% in the focused ultrasound. This is statistically significant, the difference between the sham and the treatment effect with the tremor rating scale. But when you look at the UPDRS rating system, we saw a 2-point difference in the sham group and the focused ultrasound group, but it was not statistically different. So the measuring tool mattered a little bit in this particular clinical trial. This was our pre-specified primary outcome measure. So we specified this in the design of the trial before it was even conducted, that this would be our primary outcome measure. Just a couple other measures. There was an improvement in both groups with the PDQ-39. That's a quality of life rating scale that's specific for Parkinson's disease. So that kind of further demonstrates some placebo response. And then just to conclude, we definitely see tremor improvement statistically and clinically significant in PD tremor. The measuring tool that we used does matter somewhat. And there was definitely a notable placebo response measured in the clinical trial. So we're in the process of getting this together, in more detail for publication. Just a couple more comments. There is a clinical trial of pallidotomy for dyskinesia. Maybe dyskinesia is another type of symptom that we could just pluck off and help people with Parkinson's with. Pallidotomy is really an old procedure that works great for dyskinesia, but it's been kind of abandoned because of DBS. But we definitely can see the pallidum. We have a nice image-guided target, and the device is precise for ablating it. So perhaps there's a certain role in different types of problems in Parkinson's disease where we could apply this technology. In Europe, they've done pallidothalamic tractotomies. Interestingly, at small volume lesions, there wasn't much effect in the Parkinson score, but at larger volumes, they saw more of effect. But so there are other targets that probably will be investigated depending on the center or the institution. Last thing I want to say is I talked so far about high-intensity focused ultrasound used for tissue ablation. And so the effects from the ultrasound, the effects at the focus, what I just described were the thermal effects where we get tissue ablation. But there are also mechanical effects just from perturbation of the tissue where ion channels can be opened. And there are effects from ultrasound without heating just from moving the tissue. And this is Steve. He did some of the kind of the landmark laboratory experiments on sonothrombolysis or use an ultrasound to break up blood clots without any heating. So that's one potential use for ultrasound without heating. Another one that we think is a powerful concept is neuromodulation. In other words, can we manipulate neuronal circuits, turn them on or off in a reversible fashion with ultrasound that doesn't damage or doesn't heat the brain? And so in the lab, this is our animal model. Rob Dalla Piazza is our chief resident. He did a lot of great work when he was in the lab, where he was able to suppress a somatosensory voc potential for a few minutes, and then it returned back to normal. We think that this is a kind of a powerful concept of being able to manipulate different areas deep in the brain for testing. And in an even more powerful way, I think he was able to achieve non-invasive brain mapping with low-intensity focused ultrasound. So he focused ultrasound in the thalamus of our animal model, and by moving the device just 2 millimeters, he was able to individually suppress evoke potentials either from the leg, tibial evoke responses, or median evoke responses, or trigeminal evoke responses without affecting the others. So he could individually move the transducer and suppress a single SSEP without affecting the others. Here you can see suppression of a trigeminal SSEP, but not the tibial. And then when he moves the transducer, here's the trigeminal is not affected, but the tibial is affected. So I think this demonstrates non-invasive brain mapping with ultrasound, which could be a very powerful tool or concept for the future. So just to kind of summarize the rationale for focused ultrasound lesioning, lesioning definitely can be very effective, and it might be pertinent today in our world of DBS if it can be delivered safely. So I think that's the key concept. I tell people that focused ultrasound is not better or worse than DBS. It's just different, so that they have different issues involved. Definitely the transcranial aspect is very attractive to patients and doctors. We don't call it non-invasive, at least in our institution. I think if we're doing a brain ablation, that's an invasive event. We call it transcranial. Others call it incisionalist. Some call it minimally invasive or non-invasive. But whatever, we're doing a procedure without opening the skull, and that's attractive to patients. And then it's a technology that's really amenable to careful image guidance, monitoring with MRI for precision and safety. And then some clinical issues to consider is that DBS is not perfect. It has some complexities, especially for management. It's expensive. It's labor intensive. There's hardware-related issues. So focused ultrasound could be maybe a simpler solution for a complicated problem, but its true role, really, I think, in the treatment of movement disorders is up for debate or investigation. And just to talk about the future of focused ultrasound and movement disorders, is definitely not this guy. But not this guy either. But this is Nader Parati, and he's worked with us. He's at UCLA. He's very interested in connectivity, and I think that the ability to bring advanced multimodal MRI imaging into a neurosurgery procedure is a powerful concept. So we can actually bring in fMRI or DTI into a treatment that we're doing real time. I think will be a big event for the future. And then also the ability to use low intensities for brain mapping, I think, is important, but also to open the blood-brain barrier. It's definitely been shown that ultrasound will focally open the blood-brain barrier, and I think that if we had really effective therapeutics like gene therapy or neuroprotection, we could open the blood-brain barrier and then leak out those therapeutics to the precise target that we would want to do. So I think that's the future of focused ultrasound. So once again, I'd like to thank you for not only listening, but really the opportunity to be here at this really exciting center. Thank you.